Thank you for staying with us on Daybreak. And as I mentioned, we are joined by the chair of the Social Health Authority, Dr. Abdi Mohammed. We're also joined by Dr. Tim Theory from the Kenya Federation of Health.
Kenya Healthcare Federation.
Kenya Healthcare Federation.
Yes.
All right, so we begin with page 8 of the Daily Nation, a little bit of a newspaper review as we await the other two panelists. And it reads, Ruto defends reforms in health sector, page 8 of the Daily Nation. The president says Linda Jamii has expanded scope of coverage compared to Linda Mama. And he's quoted here as saying, to defend Uhuru, we should be a bit magnanimous to him. The Linda Mama program was great for the country. We developed it under the Jubilee administration. We learned a lot from the program. And because of the lessons learned, we designed the Linda Jamii program. He added that Linda Jamii is better in scope from just delivery of mothers, which was the primary target of the Linda Mama. We now have improved it to cover prenatal, mother's delivery, and postnatal, and it no longer targets mothers, but the entire family, with the digits doubling in terms of benefits. And if you just flip to page 13, there is the editorial cartoon you'll see there. And we have welcome to State House, an image of the president trying to shush the former president, the retired president Uhuru Kenyatta, when he's saying my policies, Linda Mama, and then he's muffled. Then you have Aden Duale behind him. So I'll start with you, Chairman. It's very all well and good, Kizungu Mingi, it's okay. But we are still seeing mothers who are stranded in hospitals. We saw MTRH, mothers protesting, being held there for months. We saw in Homa Bay County, mothers saying, there's a report that was done by Mashima Kapombe, and one of the mothers said she was told to either pay 6,000 for her annual contribution or 1,000 shillings before she could receive care. She didn't have it, so she was forced to go to a mkunga, a traditional practitioner. And then I think in Thika Level 5, there was some social media footage of mothers protesting the same thing. So if indeed Linda Jamii is superior to Linda Mama, why do we have these cases?
Thank you very much. I think it's good to start from where Linda Mama started. In 2013, when the Jubilee government came into power, they abolished the 2010, which was being paid in public hospitals. 20 shilling at level health center and 10 shilling at dispensary, which was for registration fee. And the ministry was reimbursing public hospitals. In 2016, I was in the Kenya Association of Private Hospitals. We were called to the Ministry of Health, which now wanted to transition that program to NHIF instead of it being at the Ministry of Health, and expand the cover to private and faith-based facilities. Then when we had that discussion, the challenge we had was the ministry wanted to pay for the service delivery only, with 2 ANC and 1 postnatal clinic. And there was nothing else beyond that. So we debated and we said it's better if this cover is given to the family as a cover rather than paying for one event, because one event is not enough. This mother who couldn't afford will have that challenge along the way. But nonetheless, it was transitioned, and when it was transitioned, the payment reimbursement was 2,500 shilling for normal delivery to public facilities, level 2 and 3. And it was 5,000 shilling for cesarean section. While in private and FBO, that went to 17,000 for cesarean section, and it moved to 5,000 for normal delivery. If you look keenly, you will realize those are figures that were way lower than what NHIF was paying at that time for people who had super cover. If you were covered by NHIF, NHIF was reimbursing 10,000 for normal delivery and 30,000 for cesarean section. So you had two schemes. One where you are reimbursed 2,500 and another one 10,000, and then another one where you are reimbursed 6,000 and another one 17,000. That, yes, had a lot of challenges because now you have facilities claiming for the same benefit, but two different prices. It went on that way, and if you look at the Auditor General's report, parliamentary committee reports, they said it was being misused, abused. Mothers were giving 10 times within a year, and it's understandable because if you pay 2,500, it's unreasonable. And there was no way to identify what the facilities were also claiming because you did not need to have had a card of NHI for you to benefit. So it was just a claim that was coming in. So even people who had other cover were still being billed twice. So you bill the super cover and then you bill the Linda Mama. So we said that does not work in any way and help anyone. So under the Social Health Authority, what do we have? So we have a cover now that covers not only the mother, but the whole family throughout the year, from the time you join all the way to one financial year until it ends. And that's why it was being said that this is better, because this one now covers the husband, if there is one. It covers the children, other children. It covers the mother, and it's continuous. As we speak, there are 41,000 mothers below 18 who have benefited from this cover of Linda Jamii. In the other cover, which is the indigents, we have enrolled 2.2 million, which include both elderly children and even young mothers. So that is why this coverage of giving a person a premium and paying for them the premium is better than paying for one event. And if you look at...
But why do we have these cases that I've referenced?
So these cases happen because of other reasons. For example, you talked about Thika, and I was in touch with the doctor who is in charge of that Thika level 5. And I asked, what is the issue? The issue was, these are patients now who maybe did not either register, did not have anything, SHA, did not register during their ANC, did not pay, did not get the indigent cover, did not register even as underage. So there now what you have is the hospital is now stuck. But what we had asked, and that's something that the Thika Level 5 CEO told me, is they need to take this back to the Level 2 and 3 during ANC. These mothers who can't afford are recruited at that level, and that helps rather than waiting post-event. Post-event is now when you start having these debates. How do we go about it? What do we do?
So the referral system?
Yes.
Okay, so we'll just put a pin in it.
Okay.
At that point, I will invite to set Dr. Brian Lishenga, who is the chair of RUPA, Rural Urban Private Hospitals Association. Karibu sana. And I see waiting in the wings is the Member of Parliament for Nyeri Town, who is also a member of the Health Committee, Duncan Madhenge. As we mic him, good morning, Doctor. Dr. Theory.
Yeah.
Your thoughts on, so we're on page 8 of the Daily Nation, just a quick newspaper review. The president defending reforms in the health sector, and him saying that Linda Jamii is superior to Linda Mama. So I will get your thoughts on that as well. But your reaction, Dr. Theory.
I think For me, I'll start from the top coming down, and that is we've not had policy coherence as a country when it comes to healthcare. And by that I mean each time we've had a change of regime, whether at the president's level, at governor's level, whoever comes in with something that is new, comes in with something that is close to their heart, and that is what they run away with. But that is not how we run healthcare. What we should have is a blueprint for healthcare as a country that we all agree on as Kenyans, so that whoever comes in, we are able to judge them on how much acreage of that blueprint they're able to cover. So that it's not left at the desires of the manifesto making team or my disagreements with them. That is what guides policy. And that is what we are clearly seeing play out here. What Kenyans are interested in is something very simple. I want to go to hospital, I want to be seen, I want to be healthier because of that interaction. What, in my opinion, has or can be better is a communication on how we communicate these policy changes, so that if there are access rules, just like Chairman has said, Kenyans are made aware of them. So that if I'm going to hospital and I must be registered, those things should be very clear, so that we don't have any case of someone saying that I did not access care yet, perhaps I was eligible for care. So that is what we are clearly seeing. One of the things that is there is that you must be registered. So do Kenyans know that? We are in a political season, and I'm happy Mheshimiwa is here, where by-elections are happening, and we are asking our voters to register. So we are asking voters to register, but when it comes to health, we are not reminding Kenyans to not only register but also pay. All right, that is very important, because it is the access rules that SHA works with. That is just the truth. So you must not only be registered, but you must be paid up. So what we are discussing here is a scheme that is to take care of the vulnerable and indigent women. And unfortunately, we do have teenage pregnancies, and that has come out as a hot topic during this discussion. So how do we take care of them and ensure that teenage pregnancies also stop happening? Okay. Yeah.
All right. So Dr. Lishenga, if you can help, Dr. Abdi has tried to explain, the origins of Linda Mama and how it has now transitioned to Linda Jamii. But maybe you can help us understand the difference between the two, the difference between how Linda Mama operated and how Linda Jamii under SHA is operating.
Well, thank you, Olive. I think that I don't necessarily have to to be polite about this. I will just say, that one, Linda Mama and Linda Jamii are not the same. They are programs for different purposes. And some of the examples Dr. Abdi has given, that reimbursement levels were different between public hospitals, private hospitals, faith-based hospitals. At the time, when that government was in charge, they thought there were good reasons for that. Part of the reasons were that the cost of care is the same, whether you're in public, private, or faith-based. I think my colleagues know that it costs the same largely. One of the difference is that when you are in public sector, your taxes have prepaid some of the costs. So in terms of doctors have been paid from your taxes, for instance. KEMSA is supplying from your taxes equipment for hospitals.
Buildings.
So buildings, they don't pay rent, power, and such things. So some of that cost has been absorbed already by the citizens through taxation, general tax. This is common sense. So it was that argument that resulted in the differences in reimbursement. So that, for a normal delivery, as Dr. Abdi was saying, for level 2, level 3's publics, it will be maybe 2,500. It will be, a different amount as you go up. And for faith-based hospitals, by the way, it was 3,500 for level 2 and level 3. Difference of 1,000 bob. If you ask me, does 1,000 bob explain the difference in inputs between government facilities and private faith-based. It doesn't, because obviously when you are on the private side and faith-based side, you are investing everything. You are not, relying on taxes. But, be that as it may, cesarean section was 17,000 under Linda Mama. Now, there were patients who had NHIF cover that time, other than the Linda Mama cover, which was for vulnerable indigent women who only needed to prove that they are resident in Kenya. I think to some extent they were very lax in terms of what was the criteria for coming in. Now the argument that Linda Jamii is better than Linda Mama is neither here nor there, because you see the scope of coverage, the number of eligible women who are under Linda Mama was much wider, much wider. Here you have a much narrower, program, 41,000, as my colleague is saying. Under Linda Mama, we're talking about hundreds of thousands of Kenyan women. Now, let me make a very critical point here. The vulnerable and indigent population in Kenya is estimated between 8 and 10%. So we are a nation of, let's say, 50 million people. So we are estimating that somewhere between 4 million to 5 million Kenyans are indigent. The vast majority of that is going to be women, just because of economic disenfranchisement. So if you pick a number like 5 million women, and you say, 5 million Kenyans, and you ask yourself how many of those are going to be women, it's going to be somewhere like 2.75 to 3 million of that population of indigent, vulnerable Kenyans are women. Now, if you pick that 3 million number and you ask yourself how many of them are in reproductive age group, that number could easily be a third of those women. That a third of that 3 million. So we talk about 1 million women who are in reproductive age group, who are vulnerable and indigent. So here I have my colleague saying Linda Jamii is fantastic, okay, and he throws around 41,000 and we should clap, right? But we should not, because the reality of the matter is that while Linda Mama made progress, okay, and this one I have to agree, while Linda Mama made progress in social inclusion and social protection, it suffered from underfunding. It was grossly underfunded and basically relied on donors for some time. National Treasury tried to pick up the tab, but they didn't do a good job at it. So we had very little money there. It suffered other systemic issues like verification of the correct people, etc. So for me, if you ask me, was the reform necessary per se? It could have been targeted, for instance. So we know the weaknesses with Linda Mama. We know where the rain was beating us. We know it was an underfunding problem. It was a verification problem, isn't it? That doesn't mean we throw away the baby and the bathwater, and then we have political statements like Linda Jamii is better. This is ridiculous.
All right. So I will give you occasion to respond to that. But first, let's bring in the Member of Parliament for Nyeri Town, who is also a member of the Health Committee. Karibu sana, Mheshimiwa Mathenge.
Thank you.
Perhaps you can tell us, the Health Committee, has it picked up on this particular issue of Linda Mama, Linda Jamii?
Yes, Olive. And the Health Committee, since the rollout of the SHA program, has visited hospitals, facilities, including Nyeri County Referral Hospital, and Tumutumu Mission Hospital in Nyeri. And we did sample in the Central Region, in Rift Valley, and also in the Nyanza Western Region. And the concept between Linda Mama and Linda Jamii are two different concepts. While the subject of the service is the same, the indigent expectant mother, in Linda Mama, when we talk about maternal health, you cannot talk about maternal health without speaking about the health of the child, either before or after birth. And that was one gap of Leader Mama, which Leader Jamii intended to, was purposed to address. The second one, if you had this indigent mother who did not have maternity cover, did she have any health cover for the remainder of her family? And therefore, Leader Jamii is supposed to be much more inclusive. And in the same way that Dr. Rishenga is saying, that under Leader Mama, Leader Mama, we saw the gaps about, the identification, about the funding. We can juxtapose the same on Leader Jamii and see where the challenges are. One of the problems we are facing today is the fact that we want to keep referring to the NHIF Act. But Kenyans had better know that the NHIF Act is an absolute law in this country because the Social Health Insurance Act repealed that act. So we had better come to the realities and make SHA work. It is the only thing we have. The alternative is for us to go back to the drawing boards and reenact another law. And all of us here know the process and the time it would take. Our biggest weakness today are two. Number one, the shift from NHIF that used to be mandatory for everybody who was employed and had a pay slip and was voluntary for what we call the informal sector, to UHC, which is mandatory for everybody. Our weakest link is how to enforce this mandatory requirement of the Social Health Authority Act, that component. And that will take all of us. If Brian and Dr. Deuri, and they are right in desiring to have payment for their services rendered by health facilities, both public, private, and mission, in a timely manner. In fact, if possible, healthcare should be paid upfront in the same way we are paying premiums. The responsibility of mobilizing resources to support SHA and to support UHC has to be our collective responsibility. If Dr. Brian Rishenga only wants to concentrate on offering services and getting paid and does not pay attention and become interested on how to mobilize the basket from which the funds will flow, he will encounter challenges.
All right. He has made some suggestions, and I want us to take a quick break, and then we'll come to that, and then Dr. Rishenga, you'll tell us if SHA is still suspended in Rufa facilities and umefika wapi na hiyo deni. So we take a break, we come back, do share your feedback at Obaros at Citizen TV Kenya. The hashtag is Citizen Daybreak. The SMS line is 22422.